Hi everybody and welcome to our last session. Everybody's just logging in now and getting online. Sorry for the slight delay. We are always making sure that we're trying to avoid any technical difficulties. So we'll get started now that everybody is online. So thank you again for joining us for this session 6 of our series of sessions that have been taking place since September. This series of events have been organised by ISSUP and a series of partners: ISSUP South Africa, the African Union, South African National Council on Alcoholism and Drug Dependence, the Department of Social Development within the Republic of South Africa, the Organisation of American States Inter-American Drug Abuse Control Commission, and the US Department of State's Bureau of International Narcotic and Law Enforcement Affairs. And so there's a huge group that have sort of brought these events together, and we're delighted that they have been so varied. And we are now come to our last session where we can really summarise and talk about some of the key issues that perhaps we didn't have the chance to go into a little bit more detail with some of the panellists. So ISSUP's role in all of this, as most of you know, we're an international membership organisation that's really focused on the development, support and representation of a professional workforce in the substance use prevention, treatment and recovery field. And we are delighted to have 16,500 members from around the world. Our mission is to establish substance use prevention, treatment and recovery support as a unique and multidisciplinary field through the professionalisation, support and bringing together this network of professionals. So today really feels very representative of that mission, as we do come together from all corners of the globe, and we're expecting many participants again, and we've had thousands of people join us over the previous sessions, and really to go through and just revisit some of those excellent panels. Just to let you all know that interpretation will be taking place, so you can see in the chat that the instructions of how to join and listen in another language are all there. We will be having speakers, and even all of the ISSUP staff, we're all around the world working from home as everybody is. So if we have any technical difficulties, we do apologise, but please bear with us. They are unavoidable. You can go to the ISSUP website and chat with other participants of the events within the network that you've all had an email about, and that remember that all of this session and the presentations will be available to participants on the ISSUP website afterwards. So that allows me now to just welcome, first of all, my co-moderator, Livia Edegger, who's our Deputy Director, and she and I will be taking us through a number of panels, each reflecting previous sessions and talking to some of the speakers about issues that we haven't covered. And our first panel is to really focus in on the African perspective, and we have a number of speakers joining us. We have Dr. J. Ong'olo, who is a social development specialist with substantial cross-functional skills in representation and liaison. She's currently heading the Division of Social Welfare, Vulnerable Groups and Drug Control at the African Union Commission. And we're privileged to have had Jane Marie join us for many of the sessions and to be able to hear from her today. Another speaker we have is Jimena Kalawski from CICAD, and she has an extensive experience in a range of roles within the field in Chile and in Latin America. She's currently Chief of the Demand Reduction Unit at the Inter-American Drug Abuse Control Commission, as we call CICAD, within the Organisation of American States. And we also have joining us from ISSUP South Africa, Roger Weimann, who is President of ISSUP South Africa and the Director of the South African National Council on Alcoholism and Drug Dependence, the Central Eastern Cape. And Roger has been key and instrumental in bringing this event together with us. So if our three speakers would like to pop their cameras on. I know we did have a couple of difficulties with Jo Marie, but we should be able to hear her even if she's not able to, we're not able to see her. But we are going to go first of all to Jo Marie, representing the African Union Commission, to really elaborate and give us some examples of what makes the experience of Africa unique and also common to other countries in terms of drug demand reduction.
Thank you very much, Joanna. And firstly, I would like to apologize for not having my camera. I'll be addressing the question from the context, in terms of context of DDR in Africa, types of drugs, and the DDR infrastructure. Context-wise, we are talking about youthful bulging population. Africa's population is relatively very young, with 60% of the entire continent aged below 25 years. Data from our continental epidemiology network on drug use shows an increase in the number of young drug users who are showing signs of drug use disorders. And this probably supports some of the modeling projections we see that by 2050, Africa will have seen a 150% increase of drug use unless something is done now. The second contextual issue relates to drug use among displaced populations. Even though this is an emerging area that needs more research, anecdotal evidence from independent researchers shows pronounced drug use patterns amongst displaced populations in Africa. Currently, we are hosting over 1/3 of the global forced displacement population, about 17.8 million internally displaced persons, 7.4 million refugees. And for this reason, the African Union declared 2019 as the year to focus on displacement and the current year as year of silencing the gangs. But in terms of drug use, which is unique to Africa, we experience diversified range of drugs and substances that are very unique to us. Cannabis, first of all, is widely grown in Africa, and it clearly remains the most commonly used drug with a higher prevalence than the global average. The prevalence of use in Africa stands at 12.45%, higher than the global average, which is at 3.8%. And indeed, Africa accounted for almost 60% of cannabis resin seized globally in 2018. But also, we experience a big problem in our member states with alcohol use, as well as non-medical use of pharmaceutical opioids. Though the use of non-medical use of prescription drugs being a global challenge, but we in the region have a particular problem with tramadol, which are generally cheap and widely available, especially in the north, the west, and the central parts of Africa. We also experience widespread use of codeine in cough syrups. But beyond opiates and alcohol, some of the new psychoactive substances unique to us includes such drugs like smoking lizard parts and dang, which are known to possess psychoactive qualities. We also have what we call nyeupe or wonga. It's a cocktail of antiretroviral drugs, low-grade heroin, marijuana, and sometimes right poison. Another drug that is peculiar to Africa is cat, a plant-based substance not under international control. So from these experiences with the type of drugs that we see in Africa, It translates to treatment demand being mainly for alcohol and cannabis, though there's growing uptake of heroin and to a smaller extent, cocaine. Which links me to my next point on commonality. The range of treatment options remain very limited in Africa, like elsewhere in the world. Only 1 out of 18 people who need services, drug users who need services, compared to 1 out of 6 globally accessed treatment. So a lot more still needs to be done, investment on prevention, but also in Africa, something that's peculiar is that there's really no social protection coverage for persons who use drugs, especially health insurance for drug users is completely lacking. In terms of commonalities, there's growing consumption and production of drugs. A range of drugs and drug markets are expanding and diversifying as never before. Practitioners are struggling to address new challenges and new forms of addictions, especially of the new psychoactive substances. Heroin trafficking and use consumption is rising with higher HIV prevalence in IDU populations, especially along the East African coast, which remains significant entry point for heroin in Africa, both as destination and transit. So like the rest of the world, we are witnessing concentrated epidemics of HIV among drug users in populations, drug using populations, particularly injecting drug users. But as common with the other regions as well, we have developed a comprehensive approach in addressing DDR, which is aligned with UNGA's outcome document. We also have put in place a range of partnerships and collaboration, mainly to professionalize the DDR workforce, and ISSUP Forum being a very important forum for learning and experience sharing among professionals. But significantly, we are also working with the Colombo Plan on various treatment modalities for prevention, for treatment, and for recovery. As mentioned, we have what we call Continental Epidemiology Network. The systems are fledgling, and though our strategic bilateral and the systems are fledgling, and through our strategic bilateral and multilateral partners, the Commission is working with its member states to develop the skills of professionals for prevention, treatment, and care for drug users. So inclusion, I would say that even though we are in a different context, unique context, have different range of drugs that may not be common in other areas, but the overriding thing is that addressing substance use is a common and shared challenge, and we, like the rest of the world, are implementing a comprehensive approach to addressing problems associated with drug use. Thank you very much, and over to you, Joanna.
Thank you, Jane Marie. That was very thorough and much appreciated. Now, Jimena, there is a relationship that is ongoing, a dialogue between Latin America and the Caribbean and Africa. Would you like to comment from your perspective?
Yes, thank you. Good morning, good afternoon. Thank you, Joanna, Livia, Roger, and Marie. The OEA CICAD, along with our partners, are exploring new areas from collaboration among Africa, Asia, Latin America, and the Caribbean. We would like to develop a common platform to promote as an intercontinental dialogue on the prevention, treatment, and epidemiology of substance use, and to foster research, the exchange of information, and the identification of our best practices. I think that some ways in which we will work work together. We'll be sharing evaluation results, for example, share the results of the school prevention study taking place in Peru, or the outcome of the Latin American piloting training on the online UPC course, for example. We are planning a webinar on the media-based prevention program conducted by Claremont University, with participants who complete the course from America, Asia, and Latin America and Africa. Maybe they will share the experience-based prevention work that they implemented in their countries. Another thing that we can do together is to explore the possibility of preparing consolidated reports of epidemiology and sharing our best practices and technical assistance to the member states in maybe in treatment or prevention. And yes, we can continue to implement early warning system cooperation through brief training and expert presentations like the one we did it in this ISSUP meeting. We can continue to implement another initiatives in common. And I think that that's all for the moment. Maybe once again, I want to thank you, ISSUP, the South African National Chapter, SANCA, the African Union, and INL for inviting us to participate in this successful virtual conference. I am sure valuable contributions will be provided on the importance of addressing the problem of psychoactive substance use. Thank you very much.
Thank you, Jimena. And now over to you, Roger, to give us that perspective from South Africa.
Thank you. South Africa is not entirely unique from the African perspective, particularly in terms of the view of culture. This is an aspect of DDR that is necessary to take into account throughout the continent. Our continent is home to many diverse and unique cultures, ideas, and perceptions. It is these ideas and perceptions that need to influence our drug demand reduction, as well as our treatment interventions. The diverse cultures bring a unique perspective and different set of values and norms that need to be taken into consideration with every intervention in DDR. Interventions, therefore, must take culture into account. Our history as well in South Africa is part of what makes the country unique, and we have to acknowledge this. What might work well in Europe or USA might not always work in South Africa. For example, the reliance on traditional health practitioners in the South African context has a part to play in the treatment of substance use disorder. The idea of ancestors playing a vital role in the common consciousness of South Africans might not be something that is commonplace in Western cultures, but in South Africa, this is a firm part of the cultural beliefs. As such, developing a working model with the THPs in this country when dealing with DDR will have tremendous benefits. ISSUP South Africa is possibly the first organization to actively seek to involve the traditional healers, thus giving us access to rich new knowledge which has sustained the rural communities through many, many years, and which can ultimately make a tremendous difference in the way we offer substance use disorder interventions. Another aspect we must take into account when looking at the South African perspective is loosely related to Maslow's hierarchy of needs. Dealing with substance use disorder cannot be effective when the basic life essentials of the individual are not being met. It is here we have to look at the context in which the individual has engaged in substance use. We are aware and painfully aware that poverty and substance use are indelibly linked. And as such, incorporating some sort of skills development aspect into the DDR interventions is therefore beneficial. With this in mind, we look at the CADCA Community Coalitions programs and how it has proved immensely useful in a number of African countries that have welcomed the program. I am aware that in Kenya, Nigeria, and South Africa, these community coalitions have been able to become extremely strong and very active within those countries. What this is giving is a Western program that is easily adapted to the African perspective. Another thing we also have to focus on is we have to acknowledge the glamorization of alcohol use and increasingly the use of cannabis. South African culture promotes the use of alcohol as an important part of any ceremony. Alcohol has also found its way into centuries-old traditional ceremonies, and therefore we cannot overlook the way in which the country promotes the use of alcohol and the use of drug use, and how this promotion of the substance use impacts the mind of the youth within our country. In short, we must contextualize not only the individual struggling with a substance use disorder, but also the substance use itself. What are the unique set of circumstances that led to the substance use? And what can the intervention do to assist in altering these circumstances? We are aware that substance use lies at the root of many social problems experienced in our society. And evidence is suggesting that the current increase in gender-based violence in South Africa is linked to the use of alcohol. Essentially, for South Africa to be able to stem the curve of GBV, we must incorporate substance use interventions into that model. The only way that we can successfully accomplish this contextualization is through strengthening of partnerships with all stakeholders in the social welfare of the country. This conference has started that process, and let's keep the momentum and work and make the difference that we seek. I thank you.
Thank you, Roger. Now we'd like to go back to Jane Marie to talk specifically about something that Roger actually mentioned as well as a key component, and we had our panel on it in our last session. But we welcome to hear from the African Union on the role of traditional health practitioners and leaders in drug demand reduction.
Thanks again, Joanna. Considering some of the problems that I enumerated earlier on, especially issues of reach, accessibility, affordability, and fundamentally stigmatization that people with drugs and their families have to contend with, we think there's an important role for traditional health practitioners. If we have to make a significant dent, we need to involve everyone, and the involvement of THPs, as we call them, and indeed traditional leaders in general, is an imperative that cannot wait. The foundational conversation that took place last week was an eye-opener. Some of the things that we heard are that they are close to the community, promoting health and social well-being amongst individuals, families, and communities. They are often the first line of contact in many health-seeking situations. Up to 80% of people in some countries go to traditional health practitioners in the first instance. They are perceived to offer greater accessibility, acceptability, and affordability. Note, I've said that they are perceived to. As the African Union, we welcome the insights, collective wisdom, and experiences that were shared. We are convinced that there's a great role for THPs in the DDR field, as they're in many cases already providing holistic wellness, management of chronic diseases, some often co-occurring with addiction. But we also know that some of their approaches have been unorthodox in as far as the treatment of substance use is concerned, bordering on abuse of human rights, and importantly, with little or no evidence of their efficacy. So for us as the African Union Commission, the biggest question is how to bring evidence and science to bear in THP approaches, and to determine entry points for and collaborative role of THPs in the continuum of services from prevention of drug abuse and treatment to care and recovery support. As we do this, we must overcome some of the challenges which they also raised last week, which include, as we have heard in the presentations, they are not formally organized, there's non-existent or weak policy, legislation and regulation, non-integration of traditional medicine and conventional health practice, weak research and development, limited government and donor support, etc. So these are clearly areas that need strengthening along with human resource capacity building. There's opportunity and scope for working with the African Union Commission, and I'll broadly mention some of the areas where we can engage with THPs. Firstly, in the current Plan of Action on Drug Control and Crime Prevention, which promotes multi-sectoral, balanced, and integrated approach to drug control. The drug demand programs should be integrated to include everyone on board. And what we encourage member states is the formation of national steering committees or coordinating bodies that should also include THPs so that their role can be anchored in the national response. Secondly, the African Union is in the process of establishing what we call the African Medicines Agency to harmonize regulations on products such as drugs, vaccines, medical devices, blood products, diagnostic tools, and traditional medicines across Africa. This agency, AMA, will coordinate application reviews for clinical trials. And this really, where we don't have evidence, this is where we can also begin to build in some evidence. The treaty to establish AMA was endorsed by African heads of states and government in February 2019. So currently, member states are in the processes of ratification for the AMA treaty to come into force, and I'm really calling on member states to rally your support beyond AMA if THPs have to see the light of day. Thirdly, even as we're deliberating now, I am pleased to inform you that we are in the second decade of what we call African traditional medicines. The second decade is from 2011 to 2020. In recognition of enormous opportunities that traditional medicine offer in healthcare systems in Africa. But significantly, we're beginning to work with the traditional leaders in various aspects of our work. We've already established one looking at cultural practices called COTLA, Council of Traditional Leaders in Africa, and they're currently working on harmful practices such as child marriage and ending child marriage and FGM. And for sure, we welcome formation of another COTLA for drugs and substance use. And in conclusion, the African Union Commission acknowledges the potential contribution of THPs, and we therefore invite THPs to collaborate with us through some of these initiatives that I've mentioned. Thank you, and over to you, Joanna.
Thank you, Jane Marie, and thank you to all our speakers for really giving the perspective from, representing from your region and your countries. So now I'm going to hand over to Livia, who's going to moderate our next panel, focusing on prevention.
Thanks very much for the introduction, Joanna, and thanks very much to all the experts that are with us today and the ones that participated in the conference sessions earlier this year. So we'll move on to the next discussion round now, this one on prevention. As you all know, over the past decades, the prevention field has made significant advances, and we have gained valuable insights into what works in prevention and what doesn't. As a result, we have developed a much better understanding of risk and protective factors that are associated with substance use disorders. And we know that not all prevention strategies have the same impact, and some have proven ineffective or have even caused harm. So research has proven, as we know, that investing in prevention brings big returns by saving lives and money. And knowing what works in prevention and what doesn't is vital to keeping young people from developing serious and lifelong issues with substance use disorders. ISSUP as an organization is committed to sharing and promoting high quality, ethical, and evidence-based prevention. And we are excited to have our senior consultant, Jeff Lee, join us today and talk to us about the importance of prevention, the meaning of evidence-based prevention, and the role of the prevention standards. As senior consultant to ISSUP, Jeff brings a wealth of expertise and experience from working in the drug demand reduction field for almost 40 years. Jeff was previously the executive director of ISSUP, establishing the organization as an international NGO. We're also pleased to welcome the chief of UNODC's Prevention, Treatment, and Rehabilitation section, Giovanna Campello, who will provide tips and advice on prevention measures to address risk factors during the COVID-19 pandemic. Giovanna and Jeff are joined by Dr. Goodman Sibeko, the director of the International Technology Transfer Center in South Africa, also known as ITTC, and the head of the Division of Addiction Psychiatry of the Department of Psychiatry and Mental Health at the University of Cape Town. Dr. Sibeko will shed light on the importance of prevention and the prevention standards from the African perspective. Thank you all for joining us, and hopefully we can have Jeff join us now, because he would be the one providing the first speaker to provide his comments. Let's see if we can have Jeff on. If not, let's just give him a few.
Can you hear me?
Yes, we can hear you, Jeff.
Can you hear me?
Yes, we can hear you, Jeff. Could you please turn on your camera? Yeah, okay.
Try and turn on my camera.
If not, we can hear you, so you can go ahead.
If you can hear me, that's fine, because I just want to say a few words and use 4 slides just to reflect on the things that I think are important that we bear in mind when we consider the issues of prevention that came out of the session. So if we could have the first slide, it's better than looking at me anyway. I just wanted to pick up on, say, the comments that have already been made today and the questions and comments in the prevention section. I think there are just some reflections. As Livia said, 40 years is a long time, and I think how have we progressed and where have we moved to in that 40 years? And if we go to my first slide, I hope you can see that as far as I would suggest, we are in a situation where we have got to a science of prevention, where we can now actually say that prevention does work. And we've always said prevention is better than cure, but at last we are beginning to put some energy into that and some investment into that, because it's often been fine words. But now we're moving. We have a science, and the science is teaching us how we can begin to impact on the practice. So my first message and reflection would be, let's remember that prevention remains better than cure and cheaper, and it does work. Next slide, please. Can you get, is the next slide there? Can you see it? Okay, then I suppose there are, for me, some use of the word P. Prevention can often be seen as a negative, isn't it? How do we stop people doing things? How do we deal with problems and stop things? But I think we have to see prevention is a positive thing. It's something that we can do, and I think even the recent yesterday's arrival of hopefully a vaccine for COVID is about the positive way that prevention can go into practice. So it's about what we can do. It's about promoting health, about healthy lifestyles. It's about promoting healthy behavior. It's something that's very positive. And it's about pursuit of potential and possibilities. How can we deliver on the potential of humanity, of people, so that they can get the best out of life without issues around substance use or other health behavior issues. And that for me means that we should always think of prevention in terms of people and not just drugs. It's how can we focus on the people and not just the substance. My third reflection, if we move on, I'm trying to keep this brief, and so my next slide, please. It will come, please. Okay. Is we've talked a lot about the need for evidence-based practice, and ISSUP is continually trying to promote the concept of high quality, ethical and evidence-based approach to the whole issue of drug demand reduction. And that's equally true for how we should approach prevention. But I think, I'm sure Giovanna would agree, and I think in the standards document of UNODC, it always says we need more evidence. We need to find out a little bit more. The science has begun, but we're only now on the road to finding out what's effective and what works. And we have to try and get that evidence and translate it into action. So we need to continue to strive for that evidence and for the outcomes. And for me, it's about a few C's. It's about being culturally sensitive. We need a little bit more that reflects how we can go about prevention in different cultures and different societies. We have relied so long on American and European research and evidence, and we need to broaden the research and science of what is effective. We need to look at the conditions and constraints on people being able to not only undertake prevention science and research, but actually to implement it, and even to implement the research. And we've got to consider that whilst we've got the gold card of evidence base and RCTs, we have to also help people who don't have access to that sort of gold card standard. And I think we need to be clear about our objectives. Of course, we can often say we're about trying to stop people using drugs, but I think there are lots of steps on the way to that outcome, and there are different objectives that we need to achieve in that task. And therefore, we need to consider what is achievable and what is implementable in terms of outcomes. What we say has to be translated into what we do. We have to make sure, and it's been, I suppose, one of my tasks over my 40 years, gracious, is to say, how can we get theory into practice? How can we get research into reality? How can we translate what the scientists are saying, the academics are saying, into how we go about our work in the field? Next slide, please. Almost there. I'm almost finished, and when it comes, I hope.
Yeah, there, Jeff.
Well,
We
I
can
hope
see.
you can see it.
Yeah, we
No?
can.
And wait for the next slide. Is that possible?
Jeff, we can see the slide, so please.
Well, I think what I'm trying to say, it's there. Are we there? No. Well, let me say what the slide says. It's back to my how we deal with it from a legalistic point of view and law and order and so forth. Supply control still will remain. And of course, we have to deal with the issues in terms of treatment and people who suffer from substance use disorders and issues and respond to that. But we shouldn't forget the role and vital role of the midfield in providing prevention, in providing alongside prevention in that midfield, the promotion of health and the role of education, which is often missed out because we have a health agenda now. We all should, I think, have to have an education agenda if we're to achieve our prevention aims and objectives. So a team effort. And finally, if my slide was able to get there, I just wanted to say that prevention is about how we can translate what we say into what we do. And I've always done my thing of after what is all said and done, there's a lot more said than done. I think now we've got a lot we can do, and I hope we can translate our fine ideals into action to help the communities that we aim to serve around the world. Apologize for the problems of the camera and my slides, but I just wanted to give my review of what I think the focus should be for investing in prevention for the future. Thank you very much.
Thank you very much, Jeff, for your reflections and for your message on the importance of high quality, ethical and evidence-based practice in prevention, and on your focus on promoting healthy behavior and how we should focus on translating evidence and science into action. So now moving on, we have invited Giovanna Campello, the Chief of UNODC's Prevention, Treatment and Rehabilitation section, to share tips on prevention measures to address the risk factors during the pandemic that we're living through. So as you all know, during the COVID-19 pandemic, many risk factors have increased and our access to people has been reduced. We really look forward to learning more about UNODC's response. And as we know, I know earlier this week during the global pandemic, UNODC has focused their Listen First campaign materials that were initially launched in 2016 to increase the support for prevention of drug use that is based on science and is an effective investment in the well-being of our children and youth and their families and communities. And they have now especially during these times of isolation and physical distancing, relaunched those at the beginning of the week. And I'm sure Giovanna will tell us more about that. Giovanna has more than 20 years of experience with the United Nations Office on Drugs and Crime in supporting the member states and stakeholders at all levels, improving their drug prevention response, applying and contributing to scientific evidence. And since 2016, she has been leading UNODC's Prevention, Treatment and Rehabilitation section. Giovanna, the floor is yours.
This time I did remember to unmute myself. Thank you so much, Livia. Thank you to everybody for being here and ISSUP for having me and giving me the floor again. Livia, I actually, with Jeff, we had also thought that I would give some reflection, but I think they are anyway relevant also in the COVID response. So I'll do both, of course, during my allotted time. And so I wanted to give you some reflection from our sessions on prevention earlier this year, and also addressing some of the COVID question. If I could have my next slide, thank you. And so I think that my first reflection from our prevention session, and building on what Jeff was saying, is that I was really, really struck by the enormous progress that has been made in general, of course, but particularly in Africa, in evidence-based prevention, taking many and varied examples of taking evidence-based prevention, adapting it effectively. And I'm very, very happy that, sorry, now the Goodman is with us today, because some of the most effective examples of not only taking evidence-based prevention and adapting it in Africa, but generating new evidence also come from South Africa. So I'm really hoping that he will add this into his African perspective. But in general, we have examples on families, schools, communities, particularly through sports, alcohol policies. And sure, like Jeff was saying, we need to build on it. There are still too many isolated, well-intentioned, but not science-based initiatives. But, you know, let's savor the moment. Let's take a moment to pat ourselves collectively on the back and tell ourselves, well done, we need to do more of this. We have done a lot already in making prevention more evidence-based and more effective. Next slide. And to do this, I think that one of the first things that came out very clearly from the sessions is that we need to use networks to learn from each other. And of course, I'm thinking first about ISSUP, but in here, just in this small panel and in the conferences, we have been in contact with many other networks. There is the networks of our field offices, the networks of African Union, of Colombo, of the Organization of American States, other civil society networks, the networks of research and science. Let's pull together and learn from each other and use each other experience. Next. This is also because sooner or later, we will need to start building system of preventions, you know, not a bit of prevention here, a bit of prevention there. We need to start really building system of prevention at the national level. And we just cannot do this on our own. We need to pull our forces together. Everybody needs to be involved, as Jean-Marie was mentioning. Next. And I've lost my and because I think that what is really necessary is, how can I say, is for prevention practitioner to start concentrating on supporting the supporters. So think about training of trainers instead of just training practitioner or training youth. You want to train the people that are there to support children to grow healthy and safe, the families, the schools, the community centers, right? And this is really the important shift that we have seen with prevention science, and we need to move this from having small activities doing this to really create systems that support the people that are the most important in the healthy and safe development of children. And I will come to actual youth later on. But for now, this brings me to COVID. Next. I know that I'm here as part of a prevention panel, but I think that it's very, very important to, as practitioners in prevention and treatment in general, in demand reduction in general, it's really important that that we recognize that one of the first things that we need to do is to keep on working for the services for people who use drugs and people who, with drug use disorders. We need to support, everybody needs to chip in to make sure that these services continue. And not only continue and you know, provide medication take home, provide psychosocial remote, but really do not stop taking people into the services, because we have seen that the COVID put additional stress on people, and this is the moment that many people think, I really would like to do something about my drug use disorder. And we cannot afford for that door to be shut. So we have published some suggestions. CICAD has done a lot of work, and also Jean-Marie at the African Union and also the Colombo Plan. Again, let's reach out to each other to learn more on what can be done to keep those services going. Next. But this brings me to prevention. Oh my goodness, what happened to my poor slide? So for prevention, remember what I was saying about supporting the supporter. And what we have seen during the COVID is that violence against children and inequality has increased during COVID. And these are two key risk factor for future drug use and drug use disorders. And so we need to address this to protect our future generations. For example, we have seen that violence and inequality has gone up, particularly in the case where families have lost their livelihood. Violence in the family goes up. And when the kids are not in school, because the school has closed because of COVID, right? So I think that in terms of what should we do, again, let's join forces to try and support families as much as possible, socioeconomically if possible. Of course, this is where government need also to come in, and keep schools open as much as it is possible under these circumstances. And on top of that, we think that is absolutely key to support parents to cope with these stressful situations with skills in a positive way. And this is where Livia has kindly already mentioned that precisely to do that, we are launching today. In fact, the first tweet went out 1 hour ago, 10 new sets of materials of the Listen First campaign. These new materials are all about supporting families to function better, even in this challenging time. Please help us spread them. The materials on the website, you can see the URL there, are in English, French, and Spanish for now. We are translating them also in other UN languages, and we are ready to partner with anybody to translate them in any other language. We will be posting on Twitter and Facebook. You can see there the hashtags starting today and for the first 4 months. We have 10 new beautiful videos all about, they are warm, and they really promote that warm, positive parenting that is the most important protective factor in the life of children. And now, last but not the least, remember when you put something in a presentation, people will remember the first thing and the last thing. This is the last thing, and that's why I put it there for everybody to remember. Can I have the next slide? And this goes back to what Jean-Marie was saying, mobilize youth. Youth can move mountains. We have a youth initiative. You see it there. It has plenty of materials and presence on the social networks. Maybe it's not good for you. ISSUP and Colombo Plan have a youth initiative. Maybe that one is not for you. Create your own. Let us just mobilize forces to provide anything to provide youth with that opportunity to build and exercise their critical thinking in favor of science and to promote health and well-being. And again, this is very crucial on COVID. Some of the best work that has been done by our networks on COVID has been done by the youth that were involved in the Youth Forum in March. They went back energized to their communities, and they have been at the forefront of the COVID response for drug users and also in their communities. And with this, I think that my time is up, but that's quite all right, because, can I have the last slide? I just want to thank you all again for having me, and please keep well and safe, and do stay in contact. We can really move this forward. Thank you so much.
Thank you very much, Giovanna. Thanks very much for sharing your reflections and for your positive message, and really for reminding us to celebrate the success in making prevention more evidence-based altogether. And it's really so wonderful to see the progress that you mentioned in adapting evidence-based prevention, but also in generating new evidence, for example, in Africa. Thanks also for highlighting the importance of networks and the importance of working together in, as you mentioned, supporting the supporters. It is now my pleasure to welcome our next speaker, Dr. Goodman Sibeko, the Director of the International Technology Transfer Center South Africa, ITTC, and the head of the Division of Addiction Psychiatry of the Department of Psychiatry and Mental Health at the University of Cape Town. Dr. Sibeko has played an integral role in putting together the panel of the role of traditional healthcare practitioners in last week's session. So thank you very much again for your help with that. And Dr. Sibeko will now provide comments on the importance of prevention and the standards from an African perspective.
Thank you so much, Livia. It's quite a thing to have to follow Jeff and Giovanna. You know, when you speak last, you find yourself questioning everything you've written, saying, should I have said something else about that? So thank you for that pressure. And also, Jeff's talk specifically framing prevention as a positive, really, I think is something we need to keep at the back of our minds. And it's giving me pressure, and I speak now to try and see if I'm framing everything positively. So thanks, Jeff, for that. Prevention interventions broadly can be seen really as interventions that don't only prevent the occurrence of disease, such as risk factor reduction, but also arrest the progress and reduce the consequences once addiction has been established. So the initiatives which are directed at reducing the incidence of substance use related risks and harms can be divided into universal, selective, and indicated prevention. And we'll talk about that in a moment. So how I thought I would approach this, I thought about bringing in the African Union position, but I felt that it might be of more value for me to situate my talk in the South African position. Perhaps before I do that, I'll just talk about, in terms of the African Union, some of the work around education and prevention that's taking place on the continent include implementation of school, family, and community-based interventions, sort of the unplugged program, strengthening families. That's work that's being done in Nigeria and Liberia and Cote d'Ivoire and Burkina Faso and Togo and others, as well as campaign messaging on alcohol, on cannabis and other illicit drugs and psychotropics, which is happening in Ghana, Botswana, use of social media, which is very strong in Liberia and Burkina Faso, and then implementation of prevention training, which is something that we're very engaged in South Africa, as our colleagues in Uganda and Kenya. But in terms of talking about the South African context, I thought I would come at this by looking first at where we are in terms of legislation that guides the prevention efforts in the South African context, just to contextualize. So, Chapter 4 of the Prevention and Treatment of Substance Abuse Act, number 70 of 2008, outlines sort of the expected activities under prevention and early intervention services for the country. And what it really does is it provides comprehensive national response for combating substance abuse, and it provides for mechanisms which are aimed at demand and harm reduction in relation to substance abuse through prevention, early intervention, treatment, and reintegration programs. So I speak about this knowing very well that Dr. Mashabela is going to be speaking later, so he may reflect on some of what I'm talking about, and so is Dr. David Bayever, who's the chairperson of the Central Drug Authority. So in addition to providing these outlines, the Act also mandates the establishment of and also governs the operations of the Central Drug Authority, which really outlines the broader social and legislative response to drug use in South Africa. And so it provides for the establishment, and then under the establishment of the CEA under the Department of Social Development, which is the lead in combating substance abuse in the country. The CDA, or the Central Drug Authority, in turn is then tasked with developing the National Drug Master Plan, which must be adopted by Cabinet, and CDA is then further responsible for overseeing and monitoring the implementation of the National Drug Master Plan. Now, about the National Drug Master Plan, the current version is the 2019 to 2024 version. The administrative unit, as I've alluded to, of the National Drug Master Plan is a Central Drug Authority, and whose secretariat, as again, is located within the Department of Social Development. It is linked to other strategies, including the Health Sector Drug Master Plan, the Anti-Substance Abuse Program of Action, the National Anti-Gangsterism Strategy, the Draft Narcotic Strategy Action Plan, and the South African National Strategic Plan for HIV, TB, and STIs. So the value of the NDMP, or the National Drug Master Plan, is that it really comprehensively outlines the roles of the different government departments and stakeholders within and without government in achieving drug demand reduction by highlighting the importance of intersectoral collaboration. The first goal of the National Drug Master Plan is the achievement of drug demand reduction, including prevention and other health-related issues related to substance abuse. And so in promoting the multi-agency collaboration for prevention, education, and treatment, the National Drug Master Plan outlines the activities under the goal, which must then be carried out by this collaborative effort through these agencies. Some of these activities include the prevention of substance use initiation and delay. As an example, that is led collaboratively by Department of Social Development, Basic Education, Sports, Arts, Culture, and Health, with other dependents who are also part of the picture. So look, casting the net wider to include the South African Police Service, the NGOs, the civil society sector, cooperative governance, traditional leaders in South Africa. Then there's the second set of activities, which are the early intervention to prevent progression of substance use to a disorder. And there you'll find that the lead organization is social development, health, and basic education. And where the dependent organizations collaborating are the cooperative governance, traditional affairs, and correctional services, as well as home affairs. The third set of activities under this first goal of DDR, including prevention, is increasing evidence-based prevention programs. Now, part of this includes provision of information about the risks of harmful substance use as a means to prevent or to provide practical prevention of development of substance abuse. So the National Drug Master Plan further provides a prevention strategy at the it provides that that prevention strategies should be sort of presented in response to the circumstances at the local level. So there should be a local version of the Drug Master Plan in line with the National Drug Master Plan. So local leadership is intended to take the National Drug Master Plan and then develop one that is appropriate for the setting in which they are active. And then this then includes elements of primary prevention, which we can consider the universal prevention, which is interventions targeted at the general public or the whole population, where we have not yet identified what the risk is. So it's preemptive. And some of the work that's happening here is, for example, the early childhood development puppet shows, the Kimoja school-based programs, which are designed to build resilience in children, increase self-esteem, provide the correct drug information, and develop refusal skills, and also develop recreational activities to replace the time for substances through community recreational activities, offering dance, engagement through art and drama, etc. There's also underage drinking problems, which are implemented by the alcohol industry to reduce harms, as well as worth noting is, of course, that once-off interventions are never going to be sufficient. So it's about consistent collaborative efforts. Secondary interventions, which essentially involve early identification of folks at risk, and then providing interventions to arrest the progression to substance abuse, may be labeled as selective preventive interventions. These ones really target sections of population where the risk of developing a particular debility was significantly higher than the average population. So as evidenced by whatever risk factor that might be, whether it's biological, psychological, or social. So existing interventions include, early programs developed, for example, through the Child Justice Act in dealing with diversion of children to treatment facilities when they clash with the law, as well as drunk driving cases, which are referred to Centers for Assessment and Education. Key to this, of course, is the capacitation of the workforce. So training in healthcare professionals in identifying and providing brief intervention for folks who are identified as being at risk or starting to show signs of early abuse. And so this really speaks to improving community-based programs, as well as sort of really strengthening training at formal training sectors. Tertiary prevention is about, or indicated prevention is targeting those high-risk people who've been identified as having minimal but detectable signs or symptoms, and really foreshadowing and the sort of predisposition for a particular sort of debility, but who don't necessarily yet meet criteria for the disorder. And in our context, we provide this through outpatient services, through daycare, through inpatient services along that continuum of care. So as I'm about to wrap up, in general, drug demand reduction, prevention and treatment strategies, I hear the sound, it's time for me to tie up. So the focus is really on individual oriented strategies, being responsive to the environmental sort of that we're functioning in, looking at specialized services and community-based sort of services as well. We do have some unique challenges in South Africa, which I don't have a chance to go into now. And then we, you know, as alluded to by my colleagues earlier, we do have unique opportunities, for example, through the traditional health practitioner sector, to really take advantage of additional resources to achieve the prevention. Now, my closing statement is that the policy statement, the policy landscape, and the mandate for intersectoral collaboration in South Africa really therefore provides insight into the recognition of the importance of tackling substance use disorders, and the focused targeting of challenges and exploitation of available opportunities are unique to South Africa, alluded by Roger and Dr. Jane Marie earlier, indicate that we have the awareness and the tools we need to make an impact on substance use disorders.
Great, thank you very much for sharing the South African perspective and in the context with us, and really looking at legislation, the work of the Central Drug Authority, the Department of Social Development. You mentioned the importance of the National Drug Master Plan and its local versions and other strategies, and how they're all interconnected. And also thank you for mentioning the roles of the governmental departments and the other stakeholders, and really highlighting again the importance of intersectional collaboration, which again I think it was a great summary and also, like you mentioned, in the sectional collaboration, and Giovanna before mentioned the importance of networks and working all together. And so thank you again, Goodman, Giovanna, and Jeff, for your reflections and for participating in our conference. And Joanna will now introduce the next panel.
Thank you, Livia. So we are now moving on to a sort of summary and reflection of our third session of the conference, which was really a focus upon treatment and recovery. And just to quote now from the UNODC WHO International Standards for the Treatment of Drug Use Disorders. In the management of drug use disorders, the aim of treatment is to improve the health and quality of life of people with drug use disorders, and the ultimate objective is to help individuals achieve recovery to the extent possible. And the focus really of the session and the work that ISSUP does is really to encapsulate that and include the support of the recovery journey. The session, which took place on the 6th of October, included more information about those particular treatment standards, about service quality. There were some examples of best practice. We heard about universal treatment curriculum to train practitioners, and we had case studies from Latin America, Caribbean, and Africa. So it was an excellent session. During the session, we did have a range of questions, many questions, and of course, it's very difficult to ever get to all of those. But a lot of those questions were grouped around requests for information, tools and tips in terms of how the current pandemic we're facing has affected substance use disorders and those people and their communities and families who are affected by them. So we now welcome 3 speakers to give some perspective on that and some tools for you as practitioners to use during the pandemic. Our first speaker is Thom Browne, who is the CEO of the international organisation, the Colombo Plan. He's an internationally recognised expert in the demand reduction and criminal justice fields, having created substance use treatment systems and prevention programmes in over 70 countries and international law enforcement academies on 5 continents during his 25-year career at the US Department of State within INL. We'll also be hearing again from Jane Marie, who's the head of social welfare, vulnerable groups and drug control at the African Union Commission. She's a social development specialist with substantial cross-functional skills in representation and liaison advocacy, strategic management and organisational development. Then we will be hearing from David Bayever, who is the chair of the Central Drug Authority in South Africa. He's also a member of the SAHPRA Cannabis Working Committee and member of Technical Task Team on Public Health Dimensions of Narcotic Drugs and Psychotropic Substance Problems. He's a member of the Department of Health Ministerial Advisory Committee on Cannabis and the director of the South African Institute for Drug-Free Sport. So we have some excellent speakers talking to us today, and I'd like to first go to Thom to give us some perspective on how the COVID-19 pandemic and has affected substance use disorders, whether there's been an escalation and the associated impacts.
Okay, thank you, Joanna. I'd like to welcome everybody to this session, wherever you are. Good morning, afternoon, or good evening. What I'm going to start off on COVID-19 and drugs. I previously provided a webinar for ISSUP, on the overlap between COVID-19 and drugs of abuse, and I'll update some of that now. As COVID-19 has gone on, there's been more studies on it, and what we've been finding out worldwide is that people with substance use disorders are a high risk group for acquiring COVID-19. One of the most recent studies that was done, or the large-scale study that was done in the United States, was done this past September 2020 by the National Institutes of Health of the U.S. government, where they analyzed 73 million hospital records of patients who were admitted to hospitals for COVID-19. And they compared those patients who had a substance use disorder diagnosis with those who did not. And the results had found out that those patients who had a substance use disorder diagnosis were more likely to contract COVID-19, and in addition to have worse outcomes from COVID-19, including death. Now, this makes sense because when you look at which people worldwide are most vulnerable to COVID-19, we know those who are old or elderly, those that have pre-existing conditions such as diabetes, high blood pressure are at risk, but also one of the key points here is that people who have certain systems compromised are at higher risk for COVID-19. And these systems include the cardiovascular system, or the heart, the pulmonary system, the lung, the respiratory system, and the immune system. And what we know is that certain drugs of abuse are known to compromise these systems. To give an example, cocaine hydrochloride affects the cardiovascular system and the heart over time, weakening it and making a person more susceptible to, say, infections like a COVID-19. The smoking of cocaine, such as crack cocaine or coca paste, in addition to cardiovascular problems from the cocaine, the user is also susceptible to respiratory problems as it's being smoked. Methamphetamine, in research by the National Institute of Drug Abuse, has been found to compromise both the respiratory and the pulmonary system, or the lungs. Heroin has been found to compromise the pulmonary, the respiratory, and the cardiovascular system. And so over time, people with substance use disorders have these compromised systems of bodily organs, the heart, the lung, the respiratory system, and it puts them at high risk for COVID-19 and for worse consequences from it. What's equally concerning, as we addressed before in an ISSUP webinar, is the changing patterns or the changing composition of drugs worldwide, where the cutting agents for drugs have changed. And these cutting agents or adulterants have their individual properties that also affect the user, creating near and long-term chronic health problems. What's of especially concern is new cutting agents that are not meant for human consumption, especially those for veterinary use, that basically in humans, they deplete white blood cells. And when you deplete white blood cells, you basically open up the body for, you compromise the body's immune system to fight off infections and diseases. And people with depleted white blood cells are more prone to infections and diseases, including coronaviruses such as COVID-19. And we're seeing a high prevalence of unique cutting agents that have shown up worldwide. Veterinary products such as levamisole used to deworm cattle, that's now in 70% of the cocaine worldwide. And what that is doing, that is basically depleting white blood cells. Okay, and cocaine users are more susceptible to infections and diseases as a result. There are also pharmaceutical products that used to be in aspirin in the 1960s that have been removed, such as aminopyrine, because that depletes white blood cells. Another analgesic, metamizole, It's been banned in 1/3 of the world because it depletes white blood cells. The other third of the world, it's available over the counter, and the other third of the world, it's available with a prescription. The problem is these three cutting agents are finding themselves increasingly in heroin and cocaine worldwide. And instead of taking weeks to months, like a substance use disorder takes to develop, these cutting agents immediately start to go in effect, depleting white blood cells and setting up the user to a compromised immune system. And it only takes a matter of days. If you're using a more severe form of addiction, such as smoking crack cocaine or smoking methamphetamine or smoking wunga or niobe in South Africa, you'll be more prone to COVID-19, as has been shown that people say who smoke crack cocaine will smoke anywhere from 15 to 30 times a day, 7 days a week for about 6 months at one time, meaning they're going to basically severely compromise their systems, make themselves more susceptible to infections such as COVID-19. Also, substance users worldwide are now more at risk for COVID-19 because they're cut off from their peer support networks. Some of them are cut off from treatment programs, especially residential treatment programs, and they don't have that peer support that they need to basically reinforce them, to stop using drugs. What is of especially concerning is those who use in open air drug markets worldwide. Like we've seen open air drug markets like the Cracolandias in Sao Paulo, Brazil, where thousands of people will openly smoke crack cocaine. Or Wunga Park in Durban, South Africa, where you have hundreds of people smoking the marijuana heroin combination that Jean Marie spoke about, called Wunga or niobe. Or in the US, in the city of Philadelphia, the Conrail train yards, where hundreds of people are congregating and using heroin and cocaine. What happens is you have hundreds of thousands of people in open air markets worldwide using substances like heroin, methamphetamine, Wunga, niobe, cocaine, crack. And what's happening, they are not social distancing. They do not have personal protective equipment such as masks. They are sharing drug using equipment such as crack pipes and syringes. And these are breeding grounds for a COVID-19. And these people that are in the open air drug markets are at the most high risk for COVID-19 in the substance using population. On the Africa continent, which we spoke about, where we have Wunga Park in Durban, South Africa, where Wunga or niobe, the heroin marijuana combination, is smoked, those people are at high risk. People who are using tramadol, which is a synthetic opioid, which is designed for moderate to severe pain. It's not addictive as heroin, but it is addictive, and you can get a substance use disorder from it. And we had heard that tramadol is prevalent, like in Northwest and South Africa. What is concerning about this, one thing I have concerned about tramadol, for if someone who's using heroin or the opioids such as fentanyl, the antagonist naloxone is used to reverse an overdose that might occur from it. The problem with the opioid tramadol is that naloxone is not effective in reversing the overdose from tramadol because it can cause seizures. So naloxone is only partially effective in dealing with tramadol. And so if someone overdoses from tramadol, they're at especially high risk, and so this is of concern that's going on because certain drugs, so like benzodiazepine, they interfere with naloxone administration. Certain new cutting agents we discussed, those like deplete white blood cells, such as levamisole, we spoke about, those interfere with naloxone administration. So we have a situation where substance users worldwide are, especially those with substance use disorder, at a high risk for COVID-19. And because of the changing composition of the street drug supply worldwide, new combinations of drugs and cutting agents, they're not only susceptible to COVID-19 and other infections and diseases, but naloxone administration is actually compromised, and they're more at risk for drug overdose and death, we have seen. What I said before, I had done a presentation for ISSUP, on a webinar on drugs and COVID-19. I'm also with a group of colleagues. We're writing a very extensive article on the rapidly changing composition of global street drug supply and its effect on high-risk groups for COVID-19. It's 41 pages long so far. It's going to be published in the journal Current Psychopharmacology. And as soon as we get that published, I'll distribute that to ISSUP so they can put it on the ISSUP website so that members can have access to this. Okay, so basically in brief, I just covered, why substance users worldwide are more susceptible to COVID-19, and more studies are bearing this out, and also the effects of tramadol. Okay, so I'd like to thank everybody for their time, and okay, and when we get that extra research, Joanna, we'll get that to you to publish on the ISSUP website.
Thank you, Thom. That would be excellent, and I know it's requested from a lot of our members, so we appreciate the work that's going into that. Marie, so over to you in terms of the response from an African perspective, please.
Okay. Thanks again, Joanna, for giving me the floor once again. The impact of COVID across Africa has been diverse in terms of delivery of treatment and management of substance use disorders. We've not conducted any systematic study, but we've been collecting expert opinion from a number of our focal points in Africa. And the general picture is that the pandemic has resulted in closure of essential services. The quality of services have been compromised. The risk of relapse increased, and we can only assume that cases of substance use disorders have increased, but also significantly that cases of gender-based violence, especially among women who use drugs, are really on the increase. So on the specifics, one country in the East African region reported to us that their government regulations prohibited new admissions, discharge of patients, and also restricted the number of treatment professionals in the drug institutions to maintain social distancing. The impact was experienced in poor quality of services that were rendered due to reduced capacity of treatment facilities to manage drug use disorders. Secondly, loss of support networks. We've heard from treatment communities that a number of patients in recovery for a long time were starting to relapse. The social community that helped many to maintain sobriety was not there anymore, and it was difficult. Family gatherings, common in African communities, which was another social support system, were also not possible due to COVID-19 lockdowns and restrictions. Thirdly, huge loss of employment, and we can therefore assume that this has led to drug use disorders kicking in for people who are already using drugs, and some people lost employment and they were isolated, they fell into depression, predisposing them to drug use. And the fact that children were not going to school meant, for example, an additional meal. This is very significant for families struggling with resources to provide additional meal for children. This was cited by many focal points. And fourthly, the dynamics of drugs available have really changed. Anecdotal evidence indicates a spike in the local production and use of cannabis, which is widely grown in Africa. But the absence of some of the drugs alone, particularly those that are being trafficked, does not constitute treatments. People will look for alternatives, and this has created potential risk of overdose, increased risky consumption patterns, as Thom has also mentioned. For example, the ban of alcohol and cigarette sales in some African member states, especially in the southern part of Africa, has resulted in production of toxic illicit brews and underground sales. It fueled illicit economic activities of smuggling alcohol and cigarettes, and also drove many tobacco and alcohol users in experimenting with cannabis and other available drugs. But on the brighter side, In some countries, treatment centers have been innovative and initiated mobile dispensing services and channels for methadone-assisted treatment in particular. Others established scheduled dispensing cohorts to reduce the number of clients in facilities. And we've also seen a number of governments providing temporary shelters for homeless drug users, including street children. But something that's really an unintended consequence, which is really has seen positive impact on alternatives to incarceration for people with drug use disorders. Across the continent, we know that prisons are overcrowded and are under-resourced. But many African countries have taken steps to reduce prison populations, protect people in places of detention, and prevent uncontrollable outbreaks to reduce vulnerability to the COVID-19. For example, we have a very good case study in Zambia. They developed new guidelines for prevention of COVID-19, which included decongesting prisons and police holding cells to promote social distancing. This included a pilot diversion program which deals with young persons who come into contact with the law. This has enabled several people with drug use disorders to receive treatment and care in hospitals and counseling centers. Between January and August, we are talking of up to 183 persons diverted from the criminal justice systems and receiving treatment in various facilities. We also see examples of early release, as high as 50,000 in Nigeria who are released from pretrial detention centers, and up to 19,000 conditional releases in South Africa. But the question is whether or not these people who are released are connected to a continuum of care system. This is where the crux of the matter is. As we know, treatment infrastructure generally is inadequate. But I would also like to mention, as previously indicated, that the African Union has developed and is coordinating implementation of what we call the African Union Comprehensive Socioeconomic Response to COVID-19 Health Pandemic. And it includes drug control sector in some of the responses. So what we're saying is that we need the same concerted effort with which we fight COVID-19 from a pure medical perspective to overall public health approach so that we can help people overcome substance use disorders. And we also need clear policy to counteract the availability of illicit drugs. And at the same time, during this COVID-19 period, we continue to strengthen and support our epidemiological networks. Through this, as I said, we've not conducted any systematic research yet, but through this, we hope that we'll be able to ascertain what the impact of COVID-19 was, and obviously this will help us also even with future pandemics. To date, we have produced 2 continental reports covering data for the period 2017 to 2019, and for this COVID period, we are expecting to have a release early next year. And in brief, I think that's what I can say with regards to COVID-19 response. Is still work in progress with a lot of challenges for our member states. Thank you, and over to you.
Thank you very much, Jane Marie. Indeed, a challenge for all of us. So now going over to David Bayever to talk to us a little bit from the South African perspective.
Thank you very much. I'm just waiting for my screen to come up. But in the meantime, let me say thank you for the opportunity to explain the South African perspective of providing treatment to people who use or inject drugs. I have defined the treatment of substance use disorders as providing persons who are experiencing problems caused by their drug use and affording them an opportunity to maximize their physical, mental, and social abilities by involvement in a range of treatment services available. These persons can be assisted to attain their ultimate goal of freedom from drug dependence and to achieve full social reintegration if they so wish. According to the mandate of the Central Drug Authority, we are required to oversee and monitor the implementation of the National Drug Master Plan, as Goodman has already mentioned to you, which is the overarching policy framework that informs the country's response to the use of drugs, including a reduction in drug demand and supply of drugs. The interdepartmental framework aims at the resolution of substance use disorders and the mitigation of harms related to the use of illicit and licit drugs as well. The current National Drug Master Plan recognizes the relationship between drug control and human development being a complex and requiring a coordinated and multi-sectoral approach. This requires the acknowledgement of diverse social, economic, and cultural issues that consider the human rights and the expectations of all citizens. The goal is a rational...
Sorry, David.
Sorry.
Your slides are, could you make them in presentation mode just so that our participants could see them as big as possible?
Sorry, show my screen. Sorry, there we go. No.
It's the presentation mode in the PowerPoint.
Don't worry, I'll just talk to it. I'll talk to it, not a problem. So what we are saying is that it requires a diverse social, economic, and cultural issue that considers the human rights and the expectations of all our citizens. And it's mentioned by Roger before, we are a very diverse country. The goal is a rational, compassionate, evidence-based policy, and an effective response will therefore include the prevention of social marginalization and the promotion of non-stigmatizing attitudes, encouraging people who use or inject drugs to seek treatment and care, which is one of the biggest problems that we have. The policies and the goals include discouraging the onset of use and abuse of drugs, but we have to at the same time have a fallback position with a comprehensive treatment plan. By providing persons who are experiencing problems caused by their drug use with a range of treatment services, we promote mental health services with psychosocial support and counseling, medical services including detoxification, and where necessary, opioid agonist or substitution therapy as part thereof. Additionally, treatment aims at reducing the dependence on the drugs through education to reduce the negative health and social consequences caused by or associated with the use of these drugs. More importantly, the National Drug Master Plan also contains a section on harm reduction and makes reference to holistically treating users to mitigate the social, psychological, and health impact of harmful substance use by including needle and syringe programs, HIV testing services, and STI prevention. The National Drug Master Plan 2019 to 2024 is based, in our view, of a harm reduction program where we believe it's more inclusive and realistic in concept. There are well-researched, established, and successful harm reduction programs aimed at HIV and AIDS and other bloodborne infections. Rather than just accepting the drug use as a subset, we are directing our efforts to accept that harm reduction as meaning an effort aimed at primarily preventing the adverse health and social consequences of illicit and other harmful use of drugs where necessary, but at the same time reducing the HIV and other bloodborne infections. Legal services incorporate interventions in the field of criminal justice and diversion programs rather than incarceration. Family services include education, healthcare, social support, and reintegration and aftercare. Irrespective of whether a person in recovery chooses a short-term or a long-term residential program, the first 12 months post-cessation period is considered the early remission phase because social cultural components of the person's old familiar environments is likely to serve as a trigger for further use of the drugs and drinking. Temporary relocation into a controlled or monitored sober environment can be a great ally to the person in recovering during their early remission phase. This is especially the case if the individual aims to stay completely abstinent from drugs in the long term, as opposed to just cutting down or reducing harm resulting from their use. Psychosocial treatments are programs that can target components of the social and cultural structures surrounding the patient and the problematic psychological and behavioral patterns of persons in recovery, opting for outpatient treatment and eventually aftercare with a continuum of care. New evidence describes the addiction as a disease that affects both the brain and the behavior, shedding new light on our understanding of drug use and the appropriate responses. When treatment is sought by persons seeking recovery, it requires prolonged intensive patient-specific programs designed to meet the specific drugs of choice and the severity of the disorder, while addressing behavioral health needs at the same time as the person in recovery's physical health needs. Most professionals in substance use disorder treatment recognize a dynamic interplay of factors as contributing to addictive tendencies. This is why, in addition to detoxification and inpatient rehabilitation, psychological treatment are critical for the recovery from a substance use disorder. Psychosocial treatments are managed programs that can target components of the social and cultural structures surrounding the patient and the problematic psychological and behavioral patterns they develop. It's important to classify the discrimination has an impact on persons being stigmatized. For example, someone may think that a person who is a substance use or suffers from substance use disorder is weak-willed and not to be trusted, even though the person is in recovery. Stigma tends to arise when the true nature of the condition is not understood. Stigma can interfere with effective treatment of any disease, including substance use disorders. People with addiction often have other conditions or experiences that they may feel stigmatized by, such as, for example, HIV, AIDS, mental disorders, and even a criminal record. Studies have shown, though, that people with substance use disorders tend to become more dependent on drugs as a result of the stigma. So stigma is a difficult aspect of addiction because it makes it harder for the individual and the families to deal with the problem and to seek help when they need it. People who are stigmatized often internalize the hate stigma carries, transforming it to shame. The stress of hiding substance use disorder stigma carries, transforming it into shame, and either the shame to avoid the stigmatizing responses from others can cause people seeking recovery to feel that they have to cope with their problem alone, and they call this secrecy coping, and makes accessing treatment more difficult for them. Adolescents tend to hide their substance problems from their parents, and when parents do find out, stigma can make them feel guilty and ashamed. They find it harder to fight for the care and the resources that are urgently needed. Often substance use disorder treatment professionals and health professions will incorporate feedback from patients as well as from individuals closest to the patients when devising a treatment plan. In recognizing that substance use disorders is a chronic complex disease requiring prolonged continuum of care, family-related interventions was highlighted in an area which needed to be emphasized in order to provide a positive influence to recovery. This was the subject of a national conference hosted by our Minister of Social Development, Honorable Lindiwe Sisulu, in the end of 2019. At the end of that conference and through the deliberations, the Ekurhuleni Declaration was founded. That is the approach that has been adopted in South Africa in terms of the treatment towards substance abuse. Thank you for your time.
Thank you very much, David. That was an excellent summary and some really sort of did my job really of sort of pulling it together in the overarching look from the South African perspective. So we really appreciate that. We are now handing over to Livia, who's going to lead the next panel. Thank you very much, speakers.
Thank you very much, Joanna. We will now move on to discussing the importance of building a professional workforce in drug demand reduction and in providing an international focal point for access to research, training, institutional engagement, credentialing, and certification. Those of you who are familiar with our work know that the focus of ISSUP is to professionalize the drug demand reduction workforce. Our mission is to create a connected, trained, knowledgeable, an effective international network of substance use prevention, treatment, and recovery support professionals who undertake and promote high quality, evidence-based, and ethical substance use prevention, treatment, and recovery support. We deliver our mission via 3 channels: our digital communications and tools, including our website, our social media channels, and our newsletter, our in-person and virtual events such as this one, and our national chapters that undertake our work at the local level. We would like to reiterate the importance of working collaboratively and how we can all work together to offer the way to build a professional drug demand reduction workforce that's ready, able, and passionate to address the challenges that drug use brings to every community. This conference has been an excellent example of building networks and of working together and collaborating with a range of stakeholders. So thank you all again, all of our partners, for making this conference possible, and for all of you and for all the work that you do in professionalizing the drug demand reduction workforce. With us today is Dr. Kim Johnson, the Executive Director of the International Consortium of Universities for Drug Demand Reduction, also known as ICUDDR. Kim is also an Associate Research Professor at the University of South Florida. Prior to her move to Florida, she served as the Director of the Center for Substance Abuse Treatment, a U.S. federal government agency. Kim will look at the importance of professionalizing the workforce in light of the issues that were discussed in our conference. Also with us is Becky Vaughn, the Director of the Global Center for Credentialing and Certification, GCCC. She will explain the importance of credentialing and certification in professionalizing the drug demand reduction workforce. And Kim and Becky are joined by Roger Weimann, the President of ISSUP South Africa and the Director of the South African National Council on Alcoholism and Drug Dependence, CICAD Central Eastern Cape. And Roger will provide us with the insight into the development of professional drug demand reduction workforce in South Africa. Kim, over to you.
Thank you. Good afternoon, good evening, everybody. I really appreciate being invited to participate and helping to wrap up this last session. I'm going to be brief. A lot of what I had intended to say has already been said. With only 1 out of 18 people with a substance use disorder in Africa receiving treatment, there's a great need to prevent alcohol and drug use and to increase the reach of treatment services. There's also a need to be efficient by not wasting resources on ineffective practices. This international collaboration, evidenced by this ISSUP conference that's wrapping up today, that provides training, education, certification, quality assurance, and quality improvement, is a great opportunity to ensure that effective practices are implemented. However, we need to be cautious about how we define effectiveness, as most research has been conducted in populations in the United States and Europe in the context of their cultures, or our cultures, since I'm from there. I'm excited to hear about the formation of AMA by the Africa Union and the plan to conduct clinical trials research that include examining the effectiveness of traditional healing methods. We also need to monitor and assess the effectiveness of the prevention and treatment interventions that are adopted from research in other countries. Our global partnership is the perfect place to discuss what is truly universal and what is specific to certain cultures. Professionalizing the workforce needs to be done in this context. Ultimately, we need our workforce to be agile as research changes what is known to be effective. Setting a floor of competency for the various roles is important, and Becky's going to talk about that. But we must also ensure access to ongoing learning and create a process of monitoring and evaluating the systems in our countries that address alcohol and drug use, so that we evolve as the field evolves. And so that's really all I have to say. I've saved a few minutes for others. Thanks, Livia.
Oh, wonderful. Thanks very much, Kim. That was quick. So now let's move on to Becky then. So Becky is currently supporting Colombo Plan as the Director of the Global Center for Credentialing and Certification, known as GCCC, formerly ICE. And they are promoting a professionalized workforce to reduce the demand for alcohol and other drugs. Becky has served on numerous state and US federal committees and panels and speaks on the topic in a variety of settings. Over to you, Becky.
Thanks so much, Liv, and it's great to be here today. Like Kim said, I will be brief also. So much has been said. I think it was Goodman that said easier earlier that it's always hard to be at the end because you're like, oh, I should have thought of that. Oh, yeah, I didn't say that. But I'm very excited to be here today. And thanks to all of you who are also here. Many of you have attended more than one of these sessions. And I believe it's because you want to know as much as possible about this field that you have chosen to work in. You want to know what the latest research says and which best practices offer the best outcomes for the people that you work with. So why is all this training that you have taken not enough? Well, I'm glad you asked, because otherwise there wouldn't be much of a role for me. Like many professions, some type of certification is required to show that the person knows what they're doing. So why do governments often require this? I see two big reasons. First, do no harm. We work with a vulnerable population. Bad treatment is not just ineffective, it can be deadly. There are prevention practices that can actually encourage young people to use substances. And Giovanna pointed out earlier why we have standards for prevention. And inappropriate recovery support services can actually cause setbacks in people's recovery. So it's important that people be protected physically, emotionally, as well as financially. Second, there should be minimum standards. As a field, we must set those standards and ensure that practitioners are meeting them in order to work. I want you to be recognized as the professional that you are. With an international certification, you can be proud that you meet those minimum requirements and also demonstrate to governments and other employers that you have the knowledge and skill set to effectively prevent drug use and abuse and promote healthy behavior, that you can effectively treat substance use disorders, and that you can effectively support people in their recovery. Don't ever forget that you are the heroes of your community. Professionalism comes from the ability to effectively work with passion, knowledge, and skills. An international certified addiction professional, or what we refer to as our ICAP, that credential and/or certification demonstrates that you are using the latest research and evidence. If we're going to move this field forward, it means being able to show that we have a professional workforce ready to reduce the demand for drugs with dynamic prevention services, evidence-based treatment modalities, and recovery support services. I look forward to watching the professional workforce continue to grow in Africa and around the world. If you need more information about this credential, check out our website. As Liv said earlier, globalccc.org. We would love to help you. Thanks, Liv.
Thanks very much, Becky. Thanks very much again for highlighting the need for the training, but also the importance of the minimum standards. And like you mentioned, evidence-based treatment, dynamic prevention. Yeah, thank you very much for being with us here today. We will now move on to our colleague at ISSUP South Africa, Roger Weimann, who is the president of ISSUP South Africa and the director of the South African National Council on Alcoholism and Drug Dependence, SANCA, Central Eastern Cape. Roger will provide us with insights into the development of a professional drug demand reduction workforce in South Africa. And like Joanna said, this conference, we wouldn't have been able to organize this conference without Roger's help, commitment, and expertise. So thank you very much, Roger, for that.
Thank you, and thank you to Kim and to Becky for those insights. You really have summed up a lot of what I was going to say, so I'm also going to be extremely brief. Substance use disorder treatment in South Africa has long been seen as falling within the specialized fields of social work, medicine, etc. The truth, however, is that substance use treatment and intervention is a specialized field within those specialized fields, and one that needs to be professionalized beyond its current position. Thanks to organizations such as ISSUP, Colombo Plan, GCCC, and ICU-DDR, to name but a few, this is a view that is being pushed forward around the world and here in South Africa. We cannot overlook the importance of evidence-based training in the interventions offered in South Africa. Our government has introduced minimum norms and standards for the field, but sadly, these are often overlooked and in some cases difficult to monitor. As a country, South Africa could go one step further and see a regulatory body for the field of substance use intervention introduced to govern the professionalism of the field. What this could do is ensure that those offering interventions have an intimate understanding of the intricacies involved with substance use intervention. What we need really is to access the specialized training on offer by organizations such as the ICU-DDR and GCCC in the substance use field. Thankfully, with the introduction of ICU-DDR into South Africa recently, we are moving forward into a new era of substance use accreditation. The offerings of accredited tertiary education providers are invaluable in the professionalizing of the substance use disorder workforce. In 2019, the HPCSA, the Health Professionals Council of South Africa, finally recognized that the addiction psychiatry as a field within psychiatry. However, we as a country, we need to review some of the red tape involved in the professionalization of the trainings on offer. Finding a trusted drug rehabilitation center is an important part of the recovery process, and I think this has been echoed several times with previous presenters, and David spoke about it in the treatment section. With an accreditation outline in place, finding the correct treatment plan for the individual could be vastly improved. And I speak not only of accreditation of the center itself, but also the staff working within that center. In South Africa, we have the Healthcare Professionals Council, the South African Council for Social Service Professionals, as well as different councils that govern the medical profession. However, none of these councils specify substance use disorder treatment as a separate field. What we are experiencing in South Africa is an increase in unaccredited substance use disorder programs and unaccredited staff offering these programs. Programs which exist in an unregulated environment run the risk of causing more harm than they intend. Professionalization is likely to create an environment that will lead to improved regulation in the substance use field and in the long term lead to a more holistic, patient-centered service. Thank you.
Thank you very much, Roger. And thank you to all three of you, Kim, Becky, and Roger, for your reflections on the importance of the professionalization of the drug demand reduction workforce, and also for your valuable inputs during these 6 conference sessions. I will now hand over to Joanna for the closing remarks.
Thank you very much, Livia. So it is my pleasure now to start our closing remarks and bring to a conclusion an incredibly successful and vibrant series of conference presentations. And we will be first hearing from Bill McGlynn, who is a Senior Advisor to the Office of Global Policy and Programs and Drug Demand Reduction within INL at the US Department of State. Thanks, Bill. Sorry, Bill, we can't hear you. Nope. I think that because it looks to us at our end, Bill, like your microphone is on, we might be having some technical difficulties. I'm just waiting for the people that are working so frantically. Would you mind, Bill, if we move on to the comments from Jane Marie and let you liaise with Olivia on what technical problems we can solve for you? Thank you. So now I'd like to hand over to Jane Marie, who we have had excellent inputs during this session from at the African Union Commission, to hear the closing remarks from African Union.
Thank you, Joanna, again. It's my pleasure on behalf of the African Union Commission to make these closing remarks. Indeed, I'm talking on behalf of my director, Madam Mariam Assise, who would have been here now. Firstly, allow me to thank you all, our distinguished global audience, for participating in the series. Without you, this conference would be in vain. I would like to sincerely thank ISSUP, the Department of Social Development of the Republic of South Africa, the U.S. State Department's Bureau for International Narcotics and Law Enforcement Affairs, INL, the Organization of American States Inter-American Drug Abuse Control Commission, OAS CICAD, the South African National Council on Alcoholism and Drug Dependence, SANCA, for really working hand in hand and with the African Union Commission to organize this virtual conference on drug demand reduction and epidemiology in Africa. It has demonstrated what working together really means. I also acknowledge the input of other partners, including UNODC, the Colombo Plan, ITTC, ICUDDR, and other organizations that I cannot enumerate because of time. We thank you for your deliberations and collective vision. Throughout the 6 webinars of this virtual conference on drug demand reduction and epidemiology in Africa, deliberations have clearly shown the need to deepen our understanding of substance use disorders and treatment and investment in the development of prevention and treatment professionals. This global event could not have come at a better time for our continent, which, as you know, as you've heard so many times in this conference, is experiencing rising consumption of drugs. The Commission of the African Union welcomes the insights, collective wisdom, and experience from the presenters as well as the delegates. No doubt such experience will be channeled into redefining our priorities and shaping our program going forward. And we really look forward to taking up some of the issues that have come from this conference with our members, focal points from our member states. Let us leave this conference with a resolve to continue our collective journey with a shared vision where our people can have greater access to evidence-based prevention and treatment opportunities. And really from the African Union Commission, we are excited. It was a super successful webinar. I thank you all. Thank you so much, ISSUP. Bravo to everyone. Thank you, and over to you, Joanna.
Thank you, Jane Marie. We'll now move on to our closing remarks from the Government of South Africa, and representing them is Dr. Pelmos Mashabela, who's Deputy Chairman of the Central Drug Authority.
Well, thank you very much, Joanna, and good afternoon to everybody. I take this opportunity really to convey our sincerest appreciation for the excellent webinar that we have seen over the last 2-3 months. It has really been one of the most exciting, innovative intervention for which we are very grateful as a country to have participated, but also to have learned so much. One of the take-home message that we have learned through this conference is really, again, a confirmation that drug use disorder is indeed a global problem, and indeed it's a global challenge. And therefore, it is very crucial for as far as we are concerned that as a member state within the AU, but also as a member state through the international bodies, we need to be working more and more together to ensure that we address this global challenge. The expertise and experience that were shared through this conference, from the Latin America and the Caribbean and the rest of the globe, and indeed from the continent, has really served as an eye-opener again, that as a country, we are not alone. This is a problem that we must all confront and work together. There has been, during this discussion over the last few webinars, a confirmation again that as the drug demand reduction practitioners, we need to really pay particular attention to the challenges of that, data and information. In that most of the times the information and the data related to this needs to be attended to, and for that we as a country, we are committing again to participate, as we have always been, to the Pan-African Epidemiology Network on Drug Use, which the AU is really coordinating, and we are willing to continuously support that. The pandemic itself once again amplified the inequalities and the poverty levels that are encountered by the most vulnerable groups within our communities. Indeed, these neglected and the vulnerable groups included, amongst others, those who use drugs. And I think in this period, we've also seen unprecedented levels of gender-based violence against women and children. And to that effect, we are saying, perhaps this is the reason why there has to be a relook at some of these policies that we are actually promoting within the drug demand reduction to ensure that we also protect the most vulnerable and the neglected amongst the society. There is a need for us to, and I think as a country, we are also making that commitment to relook at the issues around alternative sentencing options for the drug users, because there are continuous harassment by the law enforcement agencies have been brought to the fore, and there's really a need for us to look at what alternatives are we looking at. And I think from the criminal justice system, once again, we want to convey our appreciation to the session that we had where we're looking at alternative to imprisonment. The need to invest also in relation to prevention and treatment, I think by member states, is an area that we would like, again, to put before the AU, in one of our meetings that we will be organizing, to look at how much of the investment are we willing to put in to deal with the issues of drug demand reduction. But again, just as a confirmation, we are still willing to participate in the training and the research to professionalize those that are working the workforce within the area of prevention, treatment, and epidemiology as well. And once again, as a member state, we just want to appreciate and say thank you to all the organizers, all those who put together this successful conference. And again, we are saying it has been one of those innovative ideas for which we believe that it has been quite an enormous success, and we are looking forward to a lot more participation in the future. Thank you very much.
Thank you, that's much appreciated. Now we will hear from ISSUP South Africa, the President of ISSUP South Africa, Roger Weimann.
Thank you. On behalf of ISSUP South Africa, I would like to thank you for attending the closing session today and the previous 5 plenary sessions leading up to today. The conference has seen record numbers of attendees, bringing together people and professionals from all over the world. What has become evident from the plenaries held is that the dynamic field of substance use intervention has not bypassed Africa. We have been made privy to incredible progress happening all over the continent. The information shared in this conference has been beneficial to each individual and allowed us all to evaluate our own professional offering, as well as allowing us the opportunity to identify the shortfalls in that specific offering. The interest sparked by this conference tells us that there is a dire need to bring together those working within the field and for us to create a platform to share our best practice models and success stories. Enter the ISSUP organization. This conference was the start of the process, and a successful start indeed. Regional conferences such as this one have shown Africa that we are indeed part of the global drug demand reduction community, and that Africa can and is adding to the understanding of what drug demand reduction is. These conferences will in time lead to a more professional and productive drug demand reduction workforce across the continent. As ISSUP South Africa, we are immensely proud to have been the organization that hosted this conference along with the South African National Council on Alcohol and Drug Dependence, SANCA. We would like to thank ISSUP Global, the African Union Commission, the Department of Social Development South Africa, the Department of Health South Africa, the Organization of American States Inter-American Drug Abuse Control Commission, or OAS CICAD, the U.S. Department of State Bureau of International Narcotics and Law Enforcement Affairs, INL, for the many long hours and work put in to making this conference a success. ISSUP South Africa would also like to thank all of our esteemed presenters from organizations such as UNODC, ICU-DDR, and Colombo Plan, to name but a few, for making their time available to present and join the dialogue in this unique conference. And finally, to all of those who attended the conferences and interacted with ISSUP by sending comments or asking questions, your inputs are the most valuable of all. We look forward to taking the ISSUP organization forward and growing as a national chapter and as an international organization. Until the next time, I leave you with how I started on the 16th of September. Umtu, Ngumtu, Gabantu. A person is a person through other people. Thank you.
Thank you very much, Roger. Now we will listen to Jimena Kalawski, who is the Chief of Demand Reduction at CICAD OAS.
Thank you very much, Joanna. On behalf of CICAD, I want to thank you everyone because this conference was an excellent experience exchange. Now we are working so much with our ISSUP national chapters in the Americas, and maybe we would like to work in an experiences exchange with national chapters in Africa continent. We would like to have experience share with another countries of another continent, and we like too much to enjoy another conference like this. I want to thank you everyone. Thank you ISSUP, African Union, South Africa, and thank you for your time.
Thank you, Jimena. And now Thom, there we go, as if by magic. Thom Browne, who is the CEO of Colombo Plan.
Okay, were you able to get Bill McGlynn's problem solved?
Yeah, he'll be coming on.
Oh, good.
After you.
Oh, whoa, that's going to really challenge me. Okay, that's good. I'd like to thank everyone who organized this event and all the participants in it. You know, although we are challenged by a global pandemic of COVID-19, you know, there are techniques that we use to overcome some of these challenges, even though we're not able to meet in person with face-to-face interaction to form networks and bonds, at least through innovative use of digital technology, these virtual platforms that we're using, we're able to bring the world together to address the problems of addiction, prevention, treatment, recovery, and COVID-19. Hopefully, when this pandemic abates, we'll be able to meet again in the near future, and at this time we can combine both in-person meetings with the innovative technology that has developed, you know, such as these virtual platforms, to be able to get the best messages out. So once again, I'd like to thank the organizers, the participants for this event. I see this was very unique. This went over a 2-month period. It involved many continents around the world. So it shows that we are evolving and using new and more creative ways of making the best of virtual technology so we can get the message out. So like I commend this this Latin America, Africa dialogue, and I think that you should pursue more of these. You know what I mean? Especially something that took 2 months like this, because you really can't address the actual problems in one day, having a seminar in one day, spreading them out over a time period, you're able to comprehensively address all the issues you need to address. So I'd like to thank everybody for their participation. We look forward to getting together with you in the near future. And I guess we can finally turn it over to our colleague, Bill McGlynn, because I'll tell you, I know Bill for a long time. He actually wanted to close this event. So Bill's going to get to close
it. So I don't need to introduce you now, Bill. So we have Bill McGlynn speaking as Senior Advisor to the Office of Global Policy and Programs on Drug Demand Reduction at INL at the US State Department.
Well, after that very unique and great introduction by my great friend Thom Browne, and by the way, to embarrass him a little, he has played such a fundamental role in all the things that the United States Department of State and the United States is doing in drug demand reduction. So we're really honored to have him, and the fundamental contribution that the Colombo Plan is making to all these efforts. That's really a great thing to highlight, Thom and the Colombo Plan's role. I just want to briefly say what a fantastic conference, what a great focus on all the really innovative and strong work that's being done in Africa to advance drug demand reduction. We have seen many innovative elements just in this conference, such as the traditional health practitioners area, which I think is an area of great promise. Also, the role of legislators in drug demand reduction. Again, congratulations to everyone who worked so hard. And just a couple points I want to make for those who are involved. First, stay engaged with ISSUP, please. I think it's shown, ISSUP shown what a great platform it is, and all the interesting work it does with national chapters, ensuring that training is disseminated in other areas. But that is where at least we are all trying to strengthen as a platform for everyone to go to as the home for drug prevention and treatment practitioners. Secondly, we are working very hard to put as much as possible online. So in the next few weeks, you will be seeing more and more opportunities for training, particularly in of the universal treatment curriculum and the universal prevention curriculum in various forms online. And that, I think, will make it possible for more and more people to reach, to have access to this kind of opportunity. And finally, I just want to mention, please don't forget the other great organizations involved, such as the International Consortium of Universities for Drug Demand Reduction, and a new one that you will hear more about, something called the International Technology Transfer Center. That will be a vehicle for us to help use the technologies that are available to do a better job in drug demand reduction. Thank you very much, Joanna, and thank you, everyone.
Thank you, Bill. So now it's my role to say thank you very much to all of you for joining us today. We are extremely grateful to our partners, and I know that they've been listed many times, but I would just like to sort of reiterate to say thank you to them for bringing this session together. It really has been a lot of work from ISSUP South Africa, the African Union, South African National Council on Alcoholism and Drug Dependence, the Department of Social Development for the Republic of South Africa, the Organization of American States Inter-American Drug Abuse Control Commission, and the US Department of State's Bureau of International Narcotics and Law Enforcement Affairs. We've also really valued the support and input from UNODC, Colombo Plan, ICU DDR, ITTC, and of course CICCC. So many of those people you've heard from today. We're so lucky to have that range of key, engaged, knowledgeable organisations and partners, and there's no way we could have brought such a range of effective speakers and engaged the range of participants as well without them. So thank you. Thank you to our speakers as well for the really excellent inputs, giving us the time, preparing those presentations, and also doing a lot of follow-up for us on questions and presentations and things like that. And thank you to you for joining and listening. An important part behind the scenes, of course, is the staff who have all been working very hard to resolve technical issues, work on the programme, do a lot of the organisation, and their never-ending hard work is very much appreciated. We really are very privileged to be in this position as a conduit of information from such excellent sources to you, the people that are on the ground really undertaking the work. And as a field, we're strong because of that process of talking, sharing, reaching out to each other. And you, as our extensive, diverse, hardworking, dedicated, and really active network, are the essence of ISSUP, and we really appreciate you joining us and being part of these types of exchanges. We heard today earlier from the president of ISSUP South Africa to keep the momentum going, and we are particularly challenged at the moment, but I think it is important to really remember that your innovation and resilience in doing your day-to-day work, particularly at the moment during such challenging times, is inspirational, and it is making all the difference. We wish you all the best in all of your endeavours. Thank you for taking time away from them, taking time out of your incredibly busy professional lives to join us for this series of sessions. Good luck as you return back to that day-to-day work. And we hope that by joining us for this series of sessions, that it's provided with you with something to take back to that day-to-day work. And we just encourage you now to keep in touch with ISSUP and to keep in touch with each other. We really want to be able to continue to bring you all together. There's a series of ways that you can do so on the screen now. So thank you again. Keep an eye on the ISSUP website for the presentations and the recordings, and please keep on doing what you're doing and keep in touch. Thank you.